Recording in progress.
So, hello viewers, a very good evening. I'm Dr. Vinay Purohit. I'm a pharmaceutical physician and working as a medical advisor and Deputy General Manager in Medical Affairs Department of Lupin Limited, which is one among top 5 Indian biopharmaceutical organizations. It is transnational. So it gives me immense pleasure to extend to you a very warm welcome on behalf of our entire Lupin team in this special webcast that is COPD Summit. It's an international speaker program. We are greatly privileged to have among us Dr. Sidney Brahman, who is international expert joining us from New York, US. We are equally privileged to have among us Indian expert Dr. Sanjeev Mehta, who does not need any introduction and who is going to give the direction to this COPD summit and act as a moderator. Dr. Sanjeev Mehta is a chest physician. He is senior consultant in Leelavati and Arogya Nidhi Hospitals, Mumbai. He has been founder chairman of Maharashtra chapter of Indian Chest Society, founder of Lung India Foundation, Mumbai Chest Group, and also recipient presidential citation for 2018 in Chest ACCP. He is also a recipient of Dr. C.V. Ramakrishnan Oration, Indian Chest Society, and has acted as past chair, Council of Global Governors, Chest ACCP. He is a prolific teacher and researcher, and with this, would request Dr. Sanjeev Mehta to please take over to continue the scientific proceedings of our COPD summit. Over to you, sir.
Thank you very much for that kind introduction, Dr. Purohit. I'd like to thank Dr. Purohit, Pranali, and the entire Lupin team. This to me, at a very personal level, is actually a treat, not only to learn about COPD, but to have my very dear friend, Dr. Brahman, talk to us about it. Dr. Brahman needs no introduction to the Indian audience. He's, just for the academics, he's a past professor, he's a professor emeritus of pulmonary sleep medicine, critical care at the Mount Sinai School of Medicine, but he goes far beyond that. This slide does not do justice to him. Dr. Brahman started at Temple University many years ago, served in the armed forces, worked at the Walter Reed in Washington, then went on to become the professor and then the professor and head of chest medicine at Brown University, where I was privileged to have been mentored by him. That was a phenomenal experience that set me on the path of chest medicine. He has then led one of the best departments of chest medicine there, went on to then join the Icahn School of Medicine at the Mount Sinai in New York. My earliest interactions with Dr. Brahman was when he visited India, giving his phenomenal talks at various conferences here in India. He then went on to become the president of CHEST, the American College of Chest Physicians, and recently was long overdue, is now being the Master Fellow of CHEST, the American College of Chest Physicians. He's led some of the pioneering work on cough. He's in the oversight committee on the cough guidelines. A renowned speaker on COPD, old age asthma. I mean, I can go on and on. I'm talking about my friend. I could go on, and he's the chief of life. He's the life of life. So that's Lung India Foundation. I could go on, but I think what I'm going to do is I'm going to hand you over to Dr. Brahman to tell you a lot about COPD. A word or two before that, I think guys who are listening in, COPD is probably, for those who are interested in chest medicine, probably the most important aspect of chest medicine that you're going to treat. In sheer numbers, we have about 50 to 55 million Indians who suffer from COPD. So even if you did not deal with any other medicine as a chest specialist, COPD is the one you need to know about. unfortunately, in our country. Patients of COPD get missed, as they are in the rest of the world, but really missed very badly and not treated as COPD, and therefore don't get the benefit of modern therapies. So, my first thing to you is behove you to please diagnose them. And you're going to hear Dr. Bremen and how you diagnose a COPD patient. But do PFTs, and even in villages, really get your act together, get them, and then treat them as per what you're going to hear today. Lot of misinformation, lot of different treatments, but I think if you get your act together, you will serve a very large population very well, and that will see you through your practice. So we in India have a special problem. Our COPD is different. It is driven a lot by non-smoking COPD, lot by biomass fuel. We don't even know if all the medicines which are seen in the smoking COPD will also work here. Indian doctors need to get their act together, do a lot of research, and learn to treat our COPDs better. But we'll get to that in the end. Right now, I hand you to my senior colleague and friend, Dr. Bremen, to take us through his wonderful presentation. And I know you're in for a treat. So, Dr. Bremen, all yours. Thank you very much for coming and joining us.
And thank you for that lovely introduction, Dr. Sanjeev, a very, very dear friend for many, many, many years. As you see, we're going to be talking about some new insights into COPD. And I think for many, this is going to be a bit of a challenge. And you'll understand why when we get to the second part of the talk. What I'm going to do now is first introduce COPD by its definition, and the most recent definition, Gold 2021. Many of you know that there was a large initiative to better understand gold and propagate the information about gold around the world, and that started the Global Initiative on OLD, Obstructive Lung Disease, we now know as the GOLD Committee and GOLD Guidelines. GOLD Guidelines put out this year this definition, a bit shorter than previous definitions, and I'll explain in a minute what I mean by that. Well, they start out by letting us know that it's a common disease, and Dr. Sanjay just mentioned how it is really one of the most important chronic diseases in the Indian population. And it's curious that a definition then starts with the words preventable and treatable. I think that this is an unusual way to start a definition. Preventable, I think, is most important. Why? Because we recognize that so many people who are suffering COPD didn't have to. Their exposure to fossil fuels, their exposure to cigarette smoke, certainly around the world, probably the most common cause of COPD. So it is preventable, and it's the tragedy that we have such horrible disease that we have not prevented. Treatable, unusual. Why would it have to be stated that it's treatable? Well, there was for many, many years a great nihilistic approach to COPD. We couldn't have very many good drugs to COPD. I think the GOLD Committee wants us to remember that, yes, there are very effective treatments for COPD. We'll be discussing some of those treatments in a few moments. Now, the disease is characterized by persistent respiratory symptoms. We'll discuss those in a second. And airflow limitation, essentially obstructive lung disease, COPD, chronic obstructive lung disease, limitation of airflow. That's due to airway and alveolar abnormalities, usually caused by significant exposure to noxious particles and gases. Well, I've already stated, and Dr. Sanjeev mentioned how fossil fuels are so important in your country, how cigarette smoking is another important factor driving it, occupational exposures to high dust areas, also important. What does it mean by usually? Well, it's very interesting that there are other individuals who don't apparently have these exposures to noxious particles and gases who will develop fixed airway limitation, airflow limitation, COPD. For example, chronic asthmatics may develop this fixed airway obstruction. So the usually is that, yes, most of the patients we're going to see and the concentration is going to be on the smoking and fossil fuel exposures. But I think that we have to realize that there are other causes and other mechanisms of COPD. What are the symptoms? Well, you know, shortness of breath, dyspnea, cough, sputum production. one of the things that we recognize about dyspnea is that it's often a symptom that is ignored by patients. I'm getting short of breath. Well, sure, that's because I'm just getting older. Oh, I'm so out of shape. I really got to get back to exercising. And therefore, they ignore the fact that they really have a significant organic cause of their dyspnea. It's not just out of shape. So asking specific questions about shortness of breath. The question of what kind of limitations are you having? Are you having difficulties walking up hills? Are you having difficulty keeping up with people your own age? These are the specific questions, and you'll find many times that patients have not presented these symptoms to you, but you have to sort of extract them. Cough and sputum, yes, if there is continuous exposure to noxious particles, gases, such as cigarette smoking, there often is chronic cough and chronic sputum production. Although if you can get them to stop smoking, a lot of the times the cough and sputum will abate. Now, this slide reminds us of what Dr. Sanjeev had just said. It is a tremendous burden on societies and the societies around the world. It is really a leading cause of morbidity and mortality worldwide. Look at the millions of deaths globally. And as you see here, there are about 5.4 million deaths annually. There may be by that increase will occur by maybe 2060 or even before. So this is a growing concern. Here's the burden in India that has already been alluded to. The prevalence is increasing. Look at those statistics between 1990 and 2016, increasing. It's now the most common cause of non-communicable diseases related to deaths in India, and it is a problem as a cause of DALYs. Now, DALYs is not a term that most clinicians are aware of. If you're an epidemiologist, you know this. And what it is, it's a calculation. It's a calculation on years of life lost, that is the premature mortality, as well as years of healthy life lost to disability. So it's a sort of a combination of these two. And as you see here, 1.7 times higher rates of DALYs in India compared to other in others in the globe. Now, I'd like to now turn to, I think, what is perhaps one of the most important things that we'll discuss today, and that is current recommendations for COPD. What you see here is a title which tells us that we'll be escalating and de-escalating therapy depending upon the treatable trait of the patient. Now, you probably all know that we're now trying to get into more specific targets of medicine for people, trying to find traits that are more treatable in this group or that group. We know that this has been really promulgated by our understanding of precision medicine in asthma. We now recognize that asthma is not a single disease, that there are many phenotypic expressions of asthma. Phenotypes meaning the clinical characteristics of the patient, as well as many endotypes of asthma. Endotypes meaning the pathophysiology, that not this asthmatic may have a different mechanism of disease than this asthmatic. So we're trying now to take these concepts of asthma and apply them into the COPD world, finding whether there are treatable traits. Well, the two traits that you see here on this slide are shortness of breath, dyspnea, and exacerbations. So let's describe exactly what we mean. Also borrowed from the asthma world, as you probably all know, you're treating asthma, that what we do is something we call step-up care. So when a milder asthmatic is being treated, we may treat with minimal medication, perhaps low-dose inhaled corticosteroid. As the disease gets more severe, we step up, give more medications, more doses of, for example, the corticosteroid, and that's the step up. Well, we also know that there can be step down in asthma because it is a reversible airway disease. Sadly enough, there's not very much in the way of step down, but there is one area that I'm going to discuss where you can de-escalate treatment in COPD. So let's look first at the dyspnea column. We know that as symptoms begin, patients are beginning to get more short of breath, they're having limitation of activities, we may want to start them on a single agent, a LABA or LAMA. I will say that knowing, as I'm going to show you in a minute, that the combination of a long-acting beta agonist or a long-acting muscarinic antagonist, clearly the effects are much better. The efficacy is much greater with this dual therapy. And I think that there's been a shift in our approach, that why not start out with the best, the LAMA and the LABA combination treatment. And indeed, let's say that you have the patient who's on a LABA and LAMA, but they're not sort of doing well. You may want to, number one, find out whether their adherence is appropriate. Are they really taking their medicines? You may want to watch them use their inhaler to make sure that they're using it correctly. This is particularly a great problem in the elderly, where they have sometimes difficulty remembering how to use their inhaler, maybe even have maybe some physical problems why they can't use their inhalers. So we need to at least consider either switching the inhaler device or certainly going over their history of adherence. Next, dyspnea is a very nonspecific symptom. We need to investigate if patients are worsening shortness of breath, and you have them in a LABA and LAMA, and they're certainly still worsening or not getting better, at least think about some of the other comorbidities that you see with COPD. COPD obviously has significant comorbidities in the cardiovascular area. Highest incidence actually of hypertension in the COPD is the most common comorbidity, but certainly coronary artery disease, congestive heart failure, these are things you need to think about. So when you're seeing a patient with shortness of breath and you are being referred this patient, one of the things you're going to be thinking about, you should be thinking about, is lung disease, but also cardiac disease. So how are you going to distinguish between those two? Well, as Dr. Sanjeev had said a few moments ago, you need to do pulmonary function tests. Pulmonary function studies are a simple way of defining airflow obstruction and defining that the patient has COPD. We usually give a shorter acting beta agonist after the first spirogram to see whether there's reversibility. If there's complete reversibility, that's not COPD. Remember, it's got to be fixed airflow obstruction. If there's complete reversibility, you probably are dealing with an asthmatic. So we do the PFT. We find out that the dyspnea is indeed due to COPD. We start them on either a single agent or preferably, I think, a dual agent, a LABA and a LAMA. Now, many patients in the community, and this is really historical, and I won't get into why historical, but really I'm talking about 20, 30 years, where because of the asthma world using inhaled corticosteroid, and because COPD has many of the features of asthma, shortness of breath, cough, wheeze, and so forth, that very often patients with COPD were placed on an inhaled corticosteroid. And this is where the Gold Committee in 2017, just a few years ago, said, hey, we need to think about de-escalating. Not all patients with COPD are going to respond to inhaled corticosteroids, need inhaled corticosteroids. So who do you give the inhaled corticosteroid? Well, if you look down at what's written below the boxes there, you'll see that if indeed the blood eosinophil count is greater than 300 cells per microliter, that is an indication. There is this treatable trait, a specific phenotype of COPD, eosinophilic-driven COPD, high levels of eosinophils. Now, this is a regular CBC. You order a CBC, you make sure that the lab is going to give you the total eosinophil count. If that number is greater than 300, yes, you would treat with a LABA, ICS, the combination probably. And if there's still symptomatic, you may want to maybe just use a LABA-LAMA combination, single agent with an inhaled corticosteroid. We can certainly know that if indeed symptoms are more severe, particularly in those who are, as I'll mention in a second, having frequent exacerbations, triple therapy is really the way that I think most people are going now. Now, one little caveat. COPD treatment with inhaled corticosteroids has been, as I've mentioned, really going on for decades. And some of the trials early on showed a signal. And the signal was an increase in pneumonia. So if your patient is on an inhaled corticosteroid and you look back and you say, gee, he's had pneumonia a few times in the past year or two, this may be a reason for decreasing, so-called de-escalating, and getting him off the inhaled corticosteroid. Now, another indication for inhaled corticosteroid would be frequent exacerbations. And as you see here, even if the eosinophil count is lower, 2 or more exacerbations in the last year, or even just one hospitalization, that patient is at high risk. He would be a higher severity of a COPD, and indeed inhaled corticosteroid would be useful. So you start out with a LABA/LAMA. If indeed he's having these exacerbations, you put him on the ICS. Maybe you would add the LABA/LAMA, add the ICS to the LABA/LAMA, or just use the LABA itself. And indeed, this algorithm here is showing this de-escalation. If there's less than 100 eosinophils and there's no exacerbations, you may want to get them off the ICS. If there is continued exacerbations, despite the fact that you now have them on triple therapy, there are 2 other choices. The first is a drug called roflumilast. Roflumilast is a phosphodiesterase inhibitor. I'll be talking a little bit about phosphodiesterase inhibitors when we talk about future therapies, what the future is going to be like. And indeed, there is now a PDE4, phosphodiesterase 4 inhibitor called roflumilast. And it's useful in more severe COPD patients, especially those who have chronic cough and sputum expectoration. One of the problems with roflumilast is that it caused a lot of GI side effects. And the company, therefore, has done something very smart. They have given now the availability of a half-dose pill. The usual dose is 500 micrograms a day. It's a single pill a day. And you can start out with the 250 micrograms and then escalate up maybe after a few weeks if the patient is tolerating it. There's not a lot of GI side effects. This method will lead to tolerance and not a lot of side effects, so therefore patients may tolerate it. What does roflumilast does? Clearly been shown to reduce exacerbation rates in COPD patients, as has the antibiotic azithromycin. We'll talk a bit more about azithromycin in the future, part of the future therapy part of this talk. In former smokers, you don't want to use it in active smokers, but in former smokers, it too has been shown to reduce exacerbations. First was a trial was actually with erythromycin in Europe, and of course there's a lot more GI side effects. Azithromycin, very well tolerated. I think there's 2 caveats. Number one, make sure you get an echocardiogram, you look at the QTC interval. If it's elevated, since azithromycin will also increase the QTC interval, you don't want to give it to those patients. And I've had a few patients who have had hearing loss as a result, because remember, you're giving this probably a year or maybe more to reduce exacerbations. So azithromycin is part of this protocol also. Okay, now I've been mentioning over and over again LABA/LAMA. I think this is an important step in improving, number one, symptoms of COPD, the shortness of breath, and using the 2, as I'm going to show you, is better than 1. These are given in fixed dose combinations. And the amazing thing about the most recent iterations of the LABA/LAMAs is it's once a day. Think about adherence to in your COPD patient. Get up in the morning, they use their LABA/LAMA, and that's it for the rest of the day. So GOLD guidelines suggest the use of long-acting beta agonists plus muscarinic antagonists, the LABA and the LAMA, particularly in those group D patients, those that have frequent exacerbations and are quite symptomatic shortness of breath. It's more convenient for patients compared to using, obviously, 2 inhalers, one of LABA, one of LAMA. For patients with more severe symptoms, especially driven by dyspnea, by shortness of breath, or exercise limitation, this combination, the LABA/LAMA, probably is going to be your choice as initial treatment. And I mentioned again, very important because adherence is going to be much greater because it is a once-a-day combination. So let's now look at the results from one of these combinations, Indacaterol and Glycopyrronium. Indacaterol being a long-acting beta agonist, Glycopyrronium is the long-acting muscarinic antagonist. Now, as I said, once daily, that's great. Fixed dose combination, as you see here, 110 micrograms for the LAMA and 50 micrograms for the 110 micrograms for the LABA and 50 for the LAMA. Now, they clearly show this combination greater improvements in lung function, exacerbations, patient-reported outcomes like the St. George's Respiratory Questionnaire, a measure of quality of life. So this is the medication we'll show you some studies on. So here is a large study, pooled analysis of several studies, the ARISE, the SHINE, and the SPARK trials that were conducted. It's a half-year trial, as you see. And here we have the combination, Indacaterol, Glycopyrronium, versus an open label of Tiotropium, as you know, which is just a LAMA, and a Glycopyrronium itself, just a single component. And patients treated with this combination had greater improvements in the so-called trough FEV1. What is a trough FEV1? Well, if you give this to this morning and you find out what his lung function is after 24 hours, that's the trough, and that's where you see that this long-lasting combination is very effective in keeping the FEV1, the forced expiratory volume of 1 second, high. And certainly when they compared it to the single agents, these one or the other of the LAMAs, clearly the trough FEV1 was improved, the dyspnea index, how short a breath the patient was improved, the St. George's Respiratory Questionnaire was improved, and so forth. The combination won out in these trials. This is just a pictorial of what I had just said before. Here you can see the change of baseline FEV1 trough. Here's the combination versus here's the two single agents, clearly showing a significant improvement in this FEV1 measure. And indeed, on these two graphs, we see a change in baseline symptoms, improve with Indacaterol, Glycopyrronium versus the two single agents. And here we see a baseline TDI score. TDI stands for traditional dyspnea index, how short a patient is. It's a way of measuring objectively the shortness of breath. And you can see here, always the combination wins out. So in conclusion, like the GOLD guidelines say, and I think what most clinicians are now appreciating is the introduction of this combination, LABA-LAMA, as you see here, the Indacaterol Glycopyrronium, provides improvements in lung function, daily symptoms, shortness of breath, the dyspnea, health-related quality of life, rescue medication use. I didn't show you that, but indeed, they're much less likely to use their short-acting beta agonist compared to monotherapy. So I think this is really where I think the field is heading. I think most COPD patients will appreciate the single morning dose as well as this combination therapy. Now, all right, hold on to your bootstraps here. We're going to be trying something that I think may be very new to you. We're going to be talking about new approaches in COPD. As I had said to you, we have learned a lot from the asthma world. We recognized that asthma is an inflammatory disease of the airways, inflammation. And indeed, this was not really into the definitions of COPD until the 1990s. The understanding that COPD is also an inflammatory disease, different kind of inflammation, has really taken our thoughts to new areas rather than just bronchodilator area, the inhaled corticosteroid area. And just like with asthma, we're now seeing that we can give targeted therapy, the biologics, to asthmatics with specific phenotypes and genotypes that we therefore can improve the life of more severe asthmatics. So now, using that background and understanding of what's happened in the asthma world, let's see what we can do in the future with COPD. Let's first talk about some new molecules. Now, I'm going to show you a slide now that may make you a little dizzy. But first, I want to mention, since I just talked about asthma, a a group of biologic drugs called the IL-5 antagonists. There are three of them that are approved currently. There's mepolizumab and the first one approved, reslizumab, which is actually an IV infusion, weight-based, and benralizumab, which is not an anti-IL-5, it's an anti-IL-5 receptor antagonist. Now, once again, going back to the asthma world, when the IL-5 antagonists were first used for asthma, they didn't seem to work very well. And the reason they were not working very well is because they were like taking all comers, and that whole concept of targeted therapy. So who would you target if you had an anti-IL-5 IL-5 antagonist? Well, what does IL-5 do? It's a chemotactic factor for eosinophils. So when those with eosinophil-driven asthma were given these anti-IL-5s, guess what? They were showing to be very effective in decreasing exacerbation rates, in improving other outcomes like quality of life outcomes, FEV1, and so forth. So now let's jump into the COPD world. Well, in the COPD world, we know that these molecules were not effective when first given to COPD, but the subsequent trials are beginning to look at trials with mepolizumab and actually benralizumab are beginning to show that if you can target those IL-5 driven eosinophilic types of COPD, remember I had mentioned before, those high levels of eosinophils, let's say 300 cells per microliter and above, that you're dealing with another phenotype of COPD, the eosinophilic phenotype of COPD. Of course, if the patient has a history of asthma, has been smoking, let's say, for many years, has now also fixed COPD, yes, that would be another indication for this, but really more for the asthma. That would be where your thinking would be treating the asthma. But indeed, the eosinophilic phenotype is something that I think we're going to be seeing use in the future. Now, here's the dizzying slide. This slide is labeled New Molecular Targeted Drugs. So none of these have really been approved yet, but at least one of them has. But this is kind of a theoretical construct, and it is so busy and it's so difficult that I obviously am not going to talk about every single one of these lines. But I will say that we're recognizing that inhibitors of adhesion molecules. What are adhesion molecules? They make cells, inflammatory cells, stick to the airway. We know, for example, that endothelin receptors. We know that pulmonary hypertension is important. Antioxidants are important. Protease inhibitors and so forth. So we're going to get to even growth factors like TGFR or endothelial growth factors. So these are all things that we're going to be talking about one by one. But I'm just showing you the complexity of the signaling and the molecular mechanisms of COPD. So we've got a lot to talk about. And let's get, by the way, what you're seeing here is transcription factors, which are pro-inflammatory and drive the inflammation of COPD. So let's get started now. Okay. First on the list, antioxidants. Some of you may say, oh, I remember there was a study looking at N-acetylcysteine called the Bronchus study. Dr. Mark de Kramer was the lead author in this study a number of years ago. And we know that oxidative stress is very important in COPD. There are release of reactive oxygen species driven by the cigarette smoke or the noxious particles themselves. We also know that the stress induced by the noxious particles, the cigarette smoke, for example, increases the number of neutrophils in the airway, increases the number of macrophages that are in the airways, in the alveoli. The number of macrophages can be tenfold. They don't work all that well. Their function is diminished somewhat, but there are many, many of these macrophages. What's so important? These neutrophils, these macrophages contain pro-inflammatory mediators, and they also contain proteolytic enzymes. So both of these cells, as well as the cigarette smoke itself, induces the presence of reactive oxygen species and this oxidative stress that we find in the airways of patients with COPD. Now, so what do these the reactive oxygen species do? What is oxidative stress? Well, one of the things that these ROSs do, the reactive oxygen species do, is increase mucus production. And we know that's an important part of COPD. We know, for example, that they target the antiproteases. There is reduction in alpha-1 antitrypsin, which we know is important in fighting off neutrophil elastase. So if you can decrease this, and now of course there's a genetic form of this, the alpha-1 antitrypsin deficiency form, which is quite rare in India, more common in Northern Europe, and seen in the US also. But this oxidative stress also decreases the alpha-1 antitrypsin. There is an important enzyme called histone deacetylase 2, HDAC2. What HDAC2 does is it prevents the production of the pro-inflammatory mediators. It actually it sits in the histone core of the chromosome and actually will prevent HDAC will deacetylate the core of these chromosomes and therefore prevent the induction of these pro-inflammatory mediators. Well, if you look in COPD patients, the HDAC2 levels, the histone deacetylase levels, are quite low compared to normal. Now, why is this important? Because this is the mechanism that steroids work on HDAC2 by increasing HDAC2 and therefore decreasing inflammation. Well, if we don't have very much HDAC2 around, corticosteroids don't work very well. We know this. Look at the difference between asthma and COPD. COPD much less resistant to corticosteroids. Asthma quite treatable with corticosteroids. So, what is HDAC2? What are these pro-inflammatory mechanisms do? Well, they activate some of the transcription factors, which then produce the pro-inflammatory mediators, such as NF-kappa B. NF-kappa B is important in producing tumor necrosis factor alpha, TNF alpha. Also, it increases in interleukin 8. What's IL-8? It's a neutrophilic chemotactic factor, brings in more neutrophils. So you can see how this oxidative stress is quite important in COPD and does important things. Now, it'd be great if we have some antioxidants. So far, there are none on the market. The use of them has not been proven yet for sure, but I think this is something in the future that I know that a number of studies are working on. Now, what about the protease inhibitors? Well, I already mentioned the balance between proteases and antiproteases, and indeed, as you see here, there is an attempt. The silvestat actually can protect the lung tissue damage from the protease. And we know, for example, there's not only neutrophil elastase, but there are other proteases like matrix metalloprotease 9, matrix metalloprotease 12, and they're targeting these proteases with antiproteases. I think is going to be something that we're going to see more of in the future. Next, I mentioned already cytokines, and the cytokine that I mentioned before was interleukin 5. But there are a number of other very important cytokines and chemokines. Remember, a chemokine is that which brings cells in. Cytokines are usually pro-inflammatory. So targeting neutrophil inflammation. Well, how will we do that? Well, what about an anti-interleukin 8, anti-IL-8? That has led to small clinical benefits in trials of COPD. Of course, anytime you're going to be targeting neutrophils, you have to worry about the possibility of increasing the risk of infection. IL-1 also has been described as a master cytokine of inflammation. Canakinumab is an anti-IL-1. It's an IL-1 antagonist. But unfortunately, a trial so far has shown really no improvement in lung function and health status in patients. Interleukin 6, we know tocilizumab. Where have we heard that before? Certainly in the current COVID pandemic, tocilizumab being used because of the pro-inflammatory effects of interleukin 6. We know that IL-6 levels are high in the sputum of patients with COPD, high in the blood of patients with COPD, and indeed, these two markers of inflammation do predict poor outcomes, higher mortality in COPD. So this may be something in the future that we'll be seeing the use of some of these cytokine and chemokine inhibitors, but so far they're not being used in COPD. I had mentioned adhesion molecules before. Adhesion molecules, as I said, help inflammatory cells migrate and then stick to the tissue, the blood vessel especially. And we see there are a couple of examples of these adhesion molecule inhibitors that hopefully may inhibit the migration of the inflammatory cells, which are so important to producing these pro-inflammatory mediators and the oxidative stress, like that you heard about with the neutrophil and also the macrophage. So this is something I think also in the future. Now, I had already mentioned the phosphodiesterase 4 inhibitor that is roflumilast. There has been a bit of a problem with roflumilast. The problem is that there are 4 subtypes of phosphodiesterase 4. There is an anti-inflammatory subtype, which is great, but there's also a type that increases irritability of the digestive system. This causes I think it's a central effect. This causes the nausea, the vomiting, and so forth that has limited the use of this roflumilast. However, one of the exciting things that I think is going to be seen in the future is that there is now an inhaled phosphodiesterase inhibitor, PDE4 inhibitor. It's called CHF6001, and it's not available yet, but it clearly has been shown to help in blocking the inflammatory cell infiltration in COPD. Tinamilast is going to be the name of it. It's not on the market yet. It's inhaled, very safe, and it appears to be somewhat effective. So this is something that I think we're going to see in the future. Endothelin inhibitors. Well, this is a very, very interesting part of COPD. Only about 2 to 4% of patients with COPD actually have pulmonary hypertension. Now, of course, that the most important cause of pulmonary hypertension is hypoxemia. But we're now giving patients oxygen around the clock, and indeed, this has been very helpful in preventing some of the pulmonary hypertension that we used to see with COPD. However, there is that small percentage of patients with COPD that seem to have significant pulmonary hypertension. They're more severe COPD patients by lung function testing. They have more hypoxemia. They're not CO2 retainers, though. And one of the interesting things is when you look at their arteries, their pulmonary arteries, you'll see the same pathologic changes as you see with pulmonary arterial hypertension, what we used to call primary pulmonary hypertension, pulmonary arterial hypertension, so that there is some mechanisms occurring in these patients. So if that's the case, and there is this group, can we target treatment toward this pulmonary hypertension in COPD? Well, the answer is maybe. There are endothelin receptor antagonists such as bosentan. Earlier trials of bosentan were not too impressive. But some of the studies did show that while it didn't affect clinical outcomes like 6-minute walk tests or quality of life and so forth, what it did do is reduce the pulmonary artery pressure. And I think that there are now some trials that have shown that if you do have severe pulmonary hypertension, mean pressure is greater than 35, for example, if you have severe COPD, let's say stage 4, that the use of bosentan and even sildenafil, the PDE5 inhibitor, have been shown to have some effects on that group of pulmonary hypertension patients, once again, getting to the targeted therapy in COPD. Now, adenosine 2A receptors, these adenosine exerts anti-inflammatory effects. It works by enhancing cyclic AMP, as, by the way, the phosphodiesterase inhibitors do, increase cyclic AMP in the cell. And there is a trial that, as you see here, brigadenosine, which didn't really didn't fly. It didn't really result in improvement in FEV1 compared to placebo. But I think this is at least one of the areas of investigation. Now there's a whole group of mediators. This happens to be a vasoactive peptide, a neuropeptide called VIP, and it actually has vasodilatory effects. But it also has a wide range of other biologic activities, such as anti-inflammatory effects, bronchodilation, and it has not been used in COPD, but there have been trials in severe COPD patients which appear to be positive. I think we're going to hear more about VIP in the future. This is, as you know, is more of a gastrointestinal neuromodulator, but there is some activity in the lungs, and I think we're going to hear more about the VIP in the future. Now let's talk about macrolides. I already mentioned macrolides, hadn't I? I had talked about the macrolide azithromycin. Well, it's an antibiotic, right? And we use it, obviously, for pneumonia patients. But one of the things, and certainly for acute exacerbations of COPD, but one of the things that was also recognized by the macrolides is that they also have significant anti-inflammatory effects. And they actually can block a signaling pathway that controls certain transcription factors, such as NF-kappa B and activated protein 1. These inhibit the production, therefore, downstream of inflammatory cytokines, as I said before. An example, obviously, is clarithromycin. Azithromycin will be another example. There's a newer antibiotic, solithromycin, that the trial has not really been completed, so we really don't know. But I think that the use of macrolides showing already that they can reduce exacerbations, I think is going to be going to find even more potent ones and safer ones. PPARs, peroxisome proliferator activated receptors, a mouthful. Well, you guys know about these drugs because you know about it because they're being used not for COPD but for diabetes. Rosiglitazone and pioglitazone. They are PPAR alpha agonists such as clofibrate, fenofibrate. These are all drugs that regulate the function of multiple cells. The thoughts on these strong anti-inflammatory drugs is that they may have some effect on the systemic effect of inflammation that's seen with COPD. I hadn't mentioned this before. We talked about inflammation in the lungs, but if you measure inflammatory markers in the blood of COPD patients, particularly the more severe COPD patient, the higher are inflammatory markers, such as interleukin 6, TNF alpha, and just non-specific mediators like C-reactive protein, CRP. These are all elevated in the blood of COPD patients, suggesting, not proven, that maybe some of this inflammation that's occurring in the lungs is actually spilling out into the bloodstream. And indeed, some of the systemic effects that we see in COPD patients, such as cachexia, such as muscle wasting, are obviously effects, pro-inflammatory effects of this disease, COPD. And indeed, this is where the PPARs have been used, showing some early positive findings that indeed we can decrease some of the inflammation, some of the oxidative stress, and improve muscle metabolism and systemic inflammation. And whether this plays out again in the future, we'll have to see. Well, I think enough of the molecules. This has really been a mouthful, a lot to think about. As you see, we are looking and examining many exciting pathways of inflammation in COPD, targeting different different pathways to see whether this can really improve outcomes. But there are some also newer treatments that I'll mention. Also, most not ready for prime time, very recent publications, but just so that you know about them coming down the line. Something called bronchial rheoplasty, and as you see from the publication at the bottom there, 2020. So it just last year was reported. But it's a procedure that uses non-thermal pulsed electrical fields to actually essentially ablate abnormal mucus producing cells. And this then will allow regeneration of more healthier epithelium and goblet cells, which are the mucus producing cells in the epithelium. Targeted energy delivery is intended to cause cell death. It reduces cell homeostasis, and indeed it causes an apoptosis of the cells or cell death. It doesn't really destroy the architectural function of the tissue, and actually just allows regeneration of the normal epithelium and hopefully a reduced mucus production. So bronchial rheoplasty, just as one article here. Let's see what happens. It was multi-centered. It was impressive. Let's see what happens in the future. Next, another bronchoscopic procedure of ablation. It's a novel procedure that ablates the parasympathetic innervation of the lungs. Well, we've already talked about LAMAs, how important the parasympathetic nervous system is to individuals. We actually, all of us have a cholinergic tone in the airways. And obviously, if we can release this cholinergic tone in COPD patients, causing more bronchodilation, this is done by a dual cooled radiofrequency catheter that's put into the tissue and heating the tissue, and the ablation is caused, the nerves blocking the parasympathetic signaling to the lungs, hopefully will decrease acetylcholine release and improve smooth muscle tone. Also, mucus production. Remember, mucus production is under cholinergic activity also. So, targeting lung denervation, bronchoscopic. Next, this also, I'm almost nervous to talk about this because this is absolutely not ready for prime time. The problem is, certainly in my country, that there are a number of centers that are trying to recruit patients to give them stem cells to cure their COPD, to improve their COPD. This is something that I know our government is really, our FDA is trying to stamp out, but there are centers that are telling people that stem cells can work. They are obviously cells that have unlimited self-renewal and differentiation, and the thought is that if we give certain cellular subtypes to patients, they can regenerate lung tissue. Now we know that COPD is not only an inflammatory disease of the small airways, so-called small airway bronchiolitis, inflammation of the small airways, but also, which actually is some of the earliest findings in COPD, but also the destructive changes of COPD, the emphysema of COPD, the loss of intra-alveolar septum, causing lung hyperinflation, loss of elastic recoil of the lung. So we can regenerate some of the cells that are lost. This would be wonderful. And it's so far, I mean, it's certainly, there are some studies that are undergoing, but some of the top researchers in the country on stem cell therapy, who I just recently talked to, said, don't hold your breath. This is not anything that's going to be so new, but at least we know about it and then know it's being worked on. This is a curious device. It's a sort of an oscillator, and actually it's a sound oscillator, and it actually facilitates sputum clearance. Sort of reminds you of some of the other devices, the oscillating devices that you can use. This one actually uses sound. It's new. It has been shown to reduce hospitalization, improve short-term health status. So using this to loosen the mucus in the airway and help patients expectorate it, I think is something that might be helpful for some. Robotic lung volume reduction surgery. We know that with robotic surgery and pretty much other organs, every other organ, we're going to eventually see it in the lungs. And indeed, the lung volume reduction, which has been proven to be successful in a limited number of patients who have upper airway emphysema and severe exercise intolerance, and actually improve. This is one of the rare things that has been shown to improve mortality in COPD, surgical lung volume reduction. Here, using the robotic lung technique to resect some of the abnormal lung, reduce some of that horrible hyperinflation that's seen in COPD. Just really, the device only requires 3 small incisions in the lung, and hopefully will minimize risk of infection and other complications. So this is something that I think we're going to be seeing in the future. And valve surgery. Now, this is not anything that's new. There has been even some valves that's been approved. We know that one of the major problems of valve surgery is collateral ventilation, and that there are some ways of detecting whether when you put your valve in, your bronchoscopically valve, your one-way valve into the airway, it's not going to work because of collateral ventilation. So you can actually target special areas of the lung which have emphysema. The lung volume reduction surgery is mainly just removing upper lobe emphysema, and now I think there is an approach to look at other areas in the lung, not only the upper lobe, to reduce emphysema. And obviously, it allows that hyperinflated, overexpanded lung to release air, and obviously the diaphragm comes up a little bit, and there's much better function of the diaphragm and much less of the hyperinflation, which causes just severe shortness of breath. So it has been successful and approved. Now, here we have something that's, almost kind of into the world of science here. There's a cell death that we all know about, programmed cell death, that is called, I just mentioned before, apoptosis. This is a form of cell death called necroptosis. And necroptosis is it's regulated cell death. The problem is that necroptosis, which occurs in COPD patients, is much more pro-inflammatory than apoptosis, which doesn't cause a lot of inflammation when it's cell death by apoptosis. So necroptosis is really a very pro-inflammatory state. Research suggests that it's the type of cell death associated with COPD. Now, we know that intracellular kinases are essential for blocking, for producing necroptosis, and it's blocked by a hormone called necrostatin. So developing ways to inhibit necroptosis may be important in the prevention of COPD. Now, just one other caveat before we go on to other fields, because I think this is important. It's important about all of the new therapies that we're talking about, as well as some of the old therapies. COPD is a disease of decades. I mentioned the inflammatory bronchiolitis that occurs. It occurs at a young age. I mean, heavy smokers, and you can see it in their late teens and 20s and 30s before they actually get symptomatic COPD. So what this is saying is that by looking at various mechanisms of treatment for COPD, we have to recognize that we're hitting a disease often very late in the disease. And what I guess we're going to be trying to do is prevent further decline, and especially the exacerbations. If we can find things that are going to reduce these exacerbations. Exacerbations have been associated with poor quality of life. They've been associated with worsening lung function, more rapid decline of FEV1, and they've been associated with death itself. So using some of these newer mechanisms to prevent the exacerbation, prevent decline of FEV1, I think is important. But recognizing that we're often, the horse is out of the barn, we're really dealing with the disease and often at a later stage of disease, unless we begin finding ways to identify COPD at an earlier stage, which I think would be helpful, but to date has not been a part of the public health approach. Lastly, I just have a few more minutes, and we're going to talk about some neat things, what we call patient-centric approaches. Okay, before we do that, I mean, obviously, how can a talk on anything these days go by without at least a discussion of the SARS-CoV-2 virus? We know that COPD patients have much more difficulty when they get the infection. They're not necessarily more immune to the infection, but certainly we know that all viruses are probably the most important contributors to COPD exacerbations. Most importantly, obviously, rhinovirus, the most common one, certainly in the season to come up, maybe influenza, parainfluenza, we know respiratory syncytial virus, and of course, now we have to worry about the SARS-CoV-2 virus. What we know is that the COPD patient who's not infected will just have a simple cough and shortness of breath. What if he gets sort of mild COVID-19? Well, he'll probably just have some constitutional symptoms. It's likely, because this is an airway disease, this COVID is an airway disease, that he will begin noticing some shortness of breath. He may have some dry cough, obviously fatigue, maybe he has a little diarrhea with it. And what are you going to do? Well, you're going to certainly do a chest x-ray, make sure he doesn't have concomitant pneumonia. Obviously, you're going to check his oxygen saturations. We know that it is associated with a lymphopenia, a thrombocytopenia, CRP. That nonspecific measure of inflammation is high, as is the D-dimer test. Now, let's say that we see that we do that chest x-ray and he has shortness of breath with infiltrates. Well, we know that he's now developing COVID pneumonia. And indeed, he's going to show more shortness of breath. He's then going to show plummeting levels of oxygen. His FiO2 levels are going to be low. And indeed, we're going to be considering to do further studies, again, maybe a CT to look at the extent of disease, monitor very carefully his oxygen levels, and recognize that high levels of inflammation, maybe get a calcitonin level, transaminases, just to sort of see where we are in his disease state. And then, of course, the dreaded really complication of the ARDS, the SIRS, shock, cardiac failure, and also recognizing that venous thromboembolism is very high prevalence in this group. We'll see that his oxygen levels are low. We're going to be doing a whole lot of blood tests. If we were to measure it, IL-6 levels are going to be high, looking for cardiac involvement with BMP and troponin. These are all things that either are concomitant or comorbidities of COVID-2 pneumonia. Now, yes, the patient hopefully will survive. We're going to prone him. We're going to give him high flow oxygen. And let's say he does convalesce. And here's the problem. The problem is he's going to have long standing fatigue. The average COPD patient who just has a COPD exacerbation, let's say from rhinovirus, is going to take quite a while to recover. COVID even longer. And indeed, you'll want to obviously measure his PFTs. You'll be monitoring his chest CT. And of course, you'll continue your usual COPD maintenance therapy. The possible interventions is in a non-infected patient, home exercise, some of the protective strategies. Once you get to the stage where he does have mild COPD, certainly maybe some of the therapeutic trials or actually treatments with antibodies, pooled antibodies. Obviously, the oxygen systemic steroids, remdesivir that I mentioned before, the anticoagulation that's now becoming pretty commonplace. And lastly, again, the proning, the non-invasive ventilation and so forth, and home exercise program. Pulmonary rehabilitation in the post-COVID-19 world, I think, is very, very challenging. It's certainly a very effective management strategy for COPD patients. The ATS and European respiratory societies truly say this is an important modality. Yes, exercise training, but also education, behavioral change, attention to both the physical and emotional condition of the patient. What are we doing now? Well, in this COVID era, we're beginning to do more telehealth, and telerehabilitation is becoming something that's becoming more popular. Using this telehealth mechanism to connect with patients, it'd be actually wonderful. And I know, having been stuck in many traffic jams in some of the larger cities of India, Mumbai and Chennai and so forth, I think that patients may be very happy to be able to connect with you with the telerehabilitation. It can be directed into the patient's home, or you can actually have patients coming into a healthcare facility and having several of them at a time do this. We know that there are many practical challenges and barriers to pulmonary rehabilitation. Certainly, most programs were hospital-based. It clearly can help health status. During COVID, I think we changed it to home-based. Obviously, temporary reimbursement policies are important. And in post-COVID, either hospital or home-based, maybe a hybrid, because many of these patients are going to be a long-term recovering from their COVID. What are some of the barriers? Well, you know them all. Lack of financial support, limited resources, lack of healthcare professionals. I know that one of the programs we were initiating at Mount Sinai was using home health aides to go into the house. We would give the formula, the prescription for the exercise, and they would then be helping getting patients attuned to it. Certainly transportation is a problem, and others a question. And sustainability. I mean, patients get bored with this. I had a Fitbit once, and I lasted me maybe 6 months, and I kind of got tired of it. There are really no evidence-based guidelines for tele-rehab. So during the endemic period, the American Physical Therapy Association recommends video conferencing. Prior to the pandemic, we weren't using very much of this. This is an article actually that you see here from Don Sin's group in Canada, and very few were using this form of communication with patients. During the pandemic, it's certainly increasing. Video consultations are clearly increasing in countries around the world, and Zoom appears to be, as we are doing now, probably the most important modality to connect with patients. So one last thing, your smartphone. Nowadays, we do a lot of things with our smartphone, and I think there's now evidence and algorithms that are presenting to patients who are able to use a connection with the patient on the smartphone, actually use it to measure the cough frequency, cough intensity, and so forth, and you can actually integrate audio data with this modality. However, identifying exacerbation of COPD still is going to be a bit of a problem. The automated cough sound recognition is not quite there. Auscultation maybe is going to be a difficult thing. You're trying to put the phone to your chest. I'm not so sure how well that's going to transmit through the chest wall. But there are some newer evaluations, newer technology that I think are going to be trying to look at the cough and look at airway sounds to help us actually examine the patient while they're home. So identifying the acute exacerbation of COPD, cough events, yes. Simple patient-reported symptoms will help, obviously. And ideally, the selected clinical features are going to be sort of a combination of these two. So with that, let me summarize. We talked about fixed dose LABA, LAMA, such as Indacaterol, Glycopyrronium, has absolutely clinically relevant effects, important COPD outcomes, lung function, quality of life, shortness of breath, clearly superior to the single agent, as I had mentioned before. Formulation makes it, putting these two together makes it possible to really open up, I think, a new chapter in COPD management, especially the once a day, how great that is. Bronchodilators, systemic steroids, antibiotics, obviously will continue to be interventions we use for COPD. I talked about many of the inflammatory signaling pathways that I think are going to be helpful to us to develop new therapeutic approaches to COPD. I know the ATS and ERS are very, very high on pulmonary rehabilitation. And now this COVID era has sort of introduced us to a lot of the home-based measures we could use through our telehealth and our iPhones. With that, I will thank you very much for your attention. And we'll now take any questions that you have.
Yeah. Thank you, Dr. Bremen. That was amazing. So for the audience, I hope you appreciated that Dr. Bremen in this short period of time has practically delivered a textbook on management of COPD today and tomorrow. The scope of topics that were covered was immense. Dr. Bremen, you can stop screen sharing if you'd like. Then we can get all of us on. And so I know that in the chat box, in the chat box, there have been a lot of questions. And Pranali, do you want to go with the questions or do you want me to go through the questions?
So you can take the questions.
Okay, let me start from the first one. Some of this has been covered, but let's go through this. There is Dr. Sasikala Devi from Chennai. Recent update on steroids in COPD. Which one to use and for how long? It's a very important, controversial topic.
Well, I think that guidelines for years have dissuaded us from using systemic corticosteroids, oral corticosteroids on a chronic basis for COPD. It's a drug used for asthma, but we're talking about COPD here. So that chronic use of oral corticosteroids is really not advisable. Now, for the acute exacerbation of COPD, yes. And the famous study done showing that you could use it for 2 weeks and it's effective and don't use it any longer was by Neuhoner in the late 1990s. However, a more recent article suggested that you may not need any more than 5 days of corticosteroid. So I think that the whole paradigm has really shifted to lesser doses and lesser usage in terms of a duration of time. So I would say that you can, if the patient is taking PO, you may want to use prednisolone, or in our country, prednisone. Methylprednisolone is something that you would use with intravenous in the acute exacerbation. So it really is used for the acute exacerbation, and the shorter period of time, the better. The 5 day is a target that was in the Swiss article, but honestly, sometimes even shorter period of time if the patient is showing good improvement.
Thank you. So just for Dr. Sasikala, what I would say is that we need to look at the use of steroids in 2 ways. The acute exacerbation, as Dr. Brayman said, only 5 days. The shorter, the better. But for chronic management of COPD, as he said in his talk, you're going to consider the use of inhaled corticosteroids in patients who have eosinophils in their blood, because that's a marker, surrogate marker for sputum eosinophils. So in the allergic form of COPD, you would add inhaled corticosteroids, especially if they have more than 2 exacerbations a year or 1 hospitalization. And these people would go on for a long time. Your question was which one? To the best of my knowledge, and I'll ask Dr. Brayman, it's a class effect. So you could use any inhaled corticosteroids. Obviously, again, there I would say the lower the dose, the better, because as he also told you, there's a signal for pneumonias to happen. So you do use it, but use it as minimal as possible. Dr. Brayman, about the inhaled corticosteroids in COPD, could you just a few words? I've already said some.
Yeah, I think I totally agree with what you said. I mean, there are a number of steroids. There's fluticasone and budesonide and mometasone that I think all of them have shown efficacy and usefulness. But using them in that specific group targeted patients, I think is really most important. You know, so many patients, they get a diagnosis of COPD, a primary care doctor just puts them on prednisone because that's what they did for asthma. And yet it's not necessary in those earlier stages of COPD.
Absolutely. And I think it behoves of us as doctors to make the distinction between asthma and COPD, so that in asthma is going to be long-term steroids, but in COPD, only in the subgroup. And think, because there's a tendency for pharma to push a triple therapy straight away, because it's the easy way. I think you need to be able to do that differentiation. The next question is, this is going to be a fun one. Please tell us the duration and type of vaccination in COPD. Now, this is changing in the COVID era. So, Dr. Brayman, all yours. The vaccination in COPD in the COVID era.
Yeah. Well, sadly enough, we don't have a lot of vaccinations to give in COPD. The most important one, of course, is the influenza. The problem is that studies, I've just been reading about this, the efficacy of influenza vaccinations is really poor. Maybe 40% to 60%. It really isn't. Now, so I think we have to keep that in mind. One of the things that low number tells us, though, is that if your patient is this winter, if your patient is developing flu-like symptoms, okay, yes, you think of COVID because the symptoms between COVID and influenza are absolutely identical. You can't tell the difference clinically, so therefore you got to test for both. But if that patient does test positive for influenza, I think that you need to think about some of the anti-influenza drugs. I guess in your country probably would be neuraminidase inhibitors, but with a 5-day course. But I think starting early, even sometimes before you get the results back, because it's so important that that be treated, because it does improve mortality, it shortens the course of disease. So that's the immunization of choice. Now, sadly enough, there is not good data on pneumococcal vaccination. Do we give it? Absolutely yes. But when you look at the studies in the literature on COPD, I'm not so sure what it's doing other than preventing it because you're old. And so anybody with COPD, yes. Anybody over maybe the age of 60, 65 should get pneumococcal. As far as COVID goes, I mean, absolutely yes. I mean, one of the tragedies in my country here is this anti-vax mentality, which is craziness. We don't understand it, where this comes from. It is a politically driven thing. Why these politicians who are so against masking and vaccination are doing so is sort of beyond me, and it's harming people. Now, one of the things that is being decided as we speak, actually, there's an FDA advisory group today that is looking into whether a third dose is needed with either the Pfizer or the Moderna vaccine. I think that what's going to come out, you have to realize, I was trying to explain this to my wife this morning, when the government health agencies are making decisions for the population, what they're doing is they're looking at efficacy, that's what we care about, and cost, that's what they also care about. So to balance things out, I'll give you an example of this. Years ago, the agencies in the U.S. decided that early screening for COPD isn't worth it because you wouldn't find enough cases to make it worthwhile financially. Well, I think that same thing is going to occur with COVID. Yes, they'll find that those who are immunocompromised, obviously. We mentioned tocilizumab recently with rheumatoid arthritis. Yeah, definitely. If you got an anti-TNF alpha drug or something like an anti-IL-6 drug, yes, you're going to be getting that third booster dose. Elderly people, there's a recent study that came out that showed that vaccine levels of a 30-year-old and a 75-year-old are totally different. The 75-year-old will get effective levels of the vaccine, of the antibody, but clearly about half as much as the younger individual. So I think we're going to see that it's going to be a recommendation for elderly too.
For the elderly.
And all COPD patients.
Yeah, even I think as you were speaking, I saw a flash of news that the FDA advisory has suggested that you can use the COVID vaccine with the flu vaccine. So I think that's just come out. But, absolutely, vaccination is going to be a big thing as we go forward. I'd be very interested to see what kind of COVID vaccines come out next year. I expect there will be a combo vaccine with COVID and influenza. Yeah. I expect there will be a nasal vaccine. I expect that there will be a Delta variant vaccine. But I think we need to hold on to our horses. A very interesting thing is going to happen.
One other point that I just want to mention because it's so important. Unfortunately, we don't have a vaccine. RSV, respiratory syncytial virus, which, as you know, is so deadly in very, very tiny kids, newborns and first year of life, is as important as influenza in COPD patients, also heart failure patients. a phenomenal study came out in the New England Journal that showed this, that hospitalization rate, pneumonia rate, and mortality was just as high with RSV. Sadly enough, we don't have, for adults, we don't have vaccines.
Yeah, absolutely. So I'm going to quickly ask Pranali, because as per my clock, it is 9:15 and we were going to stop at 9:15 India time. So Pranali, do we continue or do you want us to stop here?
So we can take a couple of important questions to address, and then we can take a halt.
Super.
Okay, So I think relevant to the talk, there are many important questions relevant to this talk today. There's a long question. I'll read it out and then we'll go to the question. This is from Hemlata from Bangalore, who asks, how do we need inhaled corticosteroids after an exacerbation of COPD? I think the question would have read, how long do we need inhaled corticosteroids after an exacerbation of COPD? I think much of it has been answered, but if inhaled corticosteroids, oral we've already talked about 5 to 10 days, but inhaled corticosteroids, Dr. Brayman, how long? And when do we need to switch inhaled corticosteroids to LAMA-LABA after exacerbation? I think the answer is you're going to give all three. And when do you discontinue inhaled corticosteroids in a patient of COPD? So I think you've addressed that, but Dr. Brayman?
Yeah, if a patient is having an exacerbation and you're treating him with an oral corticosteroid, and he's leaving the hospital, let's say, or leaving your office, and you give him a let's say a 5-day course of prednisolone, you're going to continue his LAMA. That's not a time to put him on inhaled corticosteroid. He doesn't need that inhaled corticosteroid. If you're then looking back and saying, oh my goodness, he's had 2-3 exacerbations in the last year, or he just got out of the hospital, then I think that's the time when you may want to consider adding the inhaled corticosteroid to his regimen. But just with an exacerbation, no, that's not an indication for the inhaled steroid.
Okay, great. There's another important question again relevant to this LAMA-LABA. Does LAMA-LABA, Indacaterol, Glycopyrronium have an effect on the frequency of exacerbations? I think it's yes.
Yes, absolutely.
So
there's no question that each component individually has shown decreased exacerbation rate, the LAMA, the LABA, and certainly the combination even more so. So the answer is definitely yes.
Definitely yes.
This is an important point. I'm glad the question came up. That I showed, just for simplicity, that there were 2 columns we were talking about the treatable trait, the dyspnea column and the exacerbation column. And many times you may have a COPD patient, you start him on a medication, and he says, I don't really feel much of anything. Indeed, if he is one of those exacerbators, you've got to keep him on the drug. You have to say to him, look, I'm giving you this medication really for several reasons. And one of those reasons is the decreased exacerbation, even though you're not feeling anything.
Absolutely. Thank you. Thank you. Another question that relates to the LAMA-LABA combination is, and if you remember, we did this survey in Mumbai on a roundtable, and at that time we discussed this. So the question is, what factor would dictate the timing of administration of this once-a-day drug? I am assuming, this is from Dr. Subhankar Chakrabarti in Kolkata. I assume what he wants to know is, would you like to give this in the morning, since it's a single drug, or would you like to give it in the evening? What do you, I think we talked about it, but
yeah.
Morning or evening?
Well, I think that since most activity is during the daytime, I would give it first thing in the morning. I don't think there's anything wrong with it at nighttime, because there is, as you know, a morning dip in lung function early hours in the morning. So, but most patients, unless your patient is maybe waking up at night with cough or something, I probably would then begin to investigate him for heart failure. But let's say that he is having more troubles at nighttime. I think that's uncommon. Morning dose would be the best, I think.
I completely agree with you. And I think we discussed that if your patient has been getting up with a lot of symptoms early in the morning, coughing, phlegm, and other things, then maybe nighttime, otherwise morning. And in such patients, I've used, because Indacaterol, I had this discussion. I found that you give Indacaterol at a different dose individually, but as a combination, it's lower. So maybe you need to give something at night. Now, there are a couple of questions which I'm going to run through, if you don't mind,
Sure.
Sydney. I think in the interest of time, how common is asthma COPD overlap syndrome? Point number one: no more a syndrome. It's a phenotype. Do you want to quickly give a one-line answer? How common is the
I think
asthma COPD overlap?
most would say about, it depends on the population, about 20%.
For 20%.
20% of COPD patients would fit into that, 15-20%, somewhere around there.
Okay. Now, most effective medical treatment, I think that we've already covered. The entire talk was on that. Then, how do you treat depression in COPD patients?
With difficulty. I think that one of the things that is has been shown over and over again is the effect of pulmonary rehabilitation is as important in terms of mood, depression, outlook of life, as it is in the physical improvement in shortness of breath. So I think that the answer is get him into that pulmonary rehab program quickly. If indeed there is really a deep depression, obviously then you would have to maybe refer him over to psychiatry. But I think that most of the time, pulmonary rehab really uplifts the spirits of the COPD patient.
I think the patient, the doctor, make him feel well, and they should do well and rehab. Do you one line, yes or no? Do you recommend melatonin to calm the sleep in COPD? Normally, we don't.
No good studies. It's a pretty benign treatment, and I would say you can try it. I don't necessarily use it. No.
Yeah. Guys, a couple of questions. Mepolizumab for COPD, do you think so? Or COPD asthma overlap? I think the trials were done. They turned.
As I said before in the talk, that there is some emerging evidence that suggests for that specific phenotype, yes, it may improve exacerbations and even lung function. So the answer is yes, either mepolizumab. There are studies in benralizumab now, the IL-5 receptor antagonist. So either of those two, yes, in that particular group. Now, someone asked the question about the asthma COPD overlap patient. I mean, those patients usually are pretty obvious. They've had allergic rhinitis or eczema as a kid. They have high IgE levels. They may have specific anti-IgE levels. They've had childhood asthma and maybe outgrew it, but they didn't really. So I think that the history that you get from those patients is usually pretty solid, letting you know that there has been that asthma in the past, and now they have, from their smoking or from their exposures, COPD on top of it.
Okay, so I'm going to have three last questions. I'll give one-line answers. If you wish to add, I'll do, because I think we are now at 9:30. What about monoclonal antibodies against COPD in the future? To the best of my knowledge, there's nothing, but if you have any thoughts. Oral magnesium in COPD, again, I'm not aware of any studies. Nebulized magnesium for asthma exacerbations, but not for COPD. And the last is any role for vitamin D in stable COPD. I think everybody loves vitamin D. So get in the sun, but I'm not aware of any. Generally, it is said to have good benefits. But very last questions. Vitamin D, then monoclonal antibodies, and oral magnesium.
I agree with everything you said. The only thing I would say about the vitamin D is the following. Many, many patients with COPD have had corticosteroid oral in the past for exacerbations. And we know that these hits of oral corticosteroid cause significant bone loss. So yes, I think as an older individual with COPD, put him on vitamin D, put him on a calcium supplement, because it's likely that he has actually the incidence of osteoporosis in women with COPD is much higher than the general women population. And also the same with men. Men usually don't get osteoporosis, but COPD men do. So great idea. Vitamin D, calcium, why not?
Always good. With that, I think we have run through the questions. Thank you, Dr. Breman.
Oh, it's been fun.
That was exhaustive. As I said, you covered the textbook of COPD today and tomorrow. That's fantastic. I see Santosh has come here to push me out. So
Absolutely not, sir. It
I
was
hand you
absolutely
over
brilliant
to,
to
and
have the
again,
two masters of respiratory medicine here today. And in the first talk of the COPD summit. So on behalf of Lupin Respira, I would like to extend my gratitude and respect to Dr. Sidney Brahman for his enlightening talk and commendable oration as ever, as always in the respiratory medicine. My sincere thanks to Dr. Sanjeev Mehta for brilliant moderation of the session. I'd like to thank all the delegates who are connected with us tonight and witnessed the upcomings and the future of the COPD, the changes which might happen in the near coming days. Along with that, without whom this particular COPD summit, today's event would not have been possible. I would like to thank Aspirant Communication team for facilitating unified coordination with Dr. Brahman. And lastly, the technical team for seamless streaming and technical support for this program. So, Dr. Brahman, many thanks, and we wish that this physical meetings will start and we will again meet you somewhere along with Dr. Mehta. So, thank you for being a part.
Thank you, Sydney. Thank you, Lupin.
Talk to you Sunday. Call me Sunday morning.
I'll call Sunday. Your Sunday morning, I'll call you. I'll definitely.
Yeah.
Okay.
Thank you, everyone.
Good night, everybody, and have a great day, Sydney. Bye.
Bye now.
Bye. Bye.